All right, welcome class. I want to do the lecture for chapters 1 through 3. This is all going to be review for the most part, but I think it's good to set the stage as we go into family therapy and just sort of switching our clinical hats from doing individual therapy to looking at the family component. And so I'll just kind of go through these slides a little bit more quickly because, like I said, it is all review. But the first chapter is on competency and theory in family therapy. All right. So as we go through these slides, I want you to think about how you would define competent therapy. You know, what specific behaviors would you have to have as a therapist that you would be able to feel confident about being a competent therapist. So think about that just for a minute. The next step is going to give us some ideas about what a competent therapy process should look like. And really it is sort of a journey or a process. And I use the analogy or the metaphor, I guess, of a map quite often when we talk about doing therapy and having an overall plan. So think about these 5 steps as symbolizing or representing a plan. And really, when you have a plan, that speaks to having more of a competent therapy session. So we are going to go through these each individually on the next several slides, but you can also see after each step, the chapter is listed where it goes into much more detail about how to do each one of these things. So mapping the territory, identifying oases and obstacles, selecting a path, tracking progress, and leaving a trail. Let's just go through these one by one. So this map, mapping the territory, mapping the big picture, just getting all the information that you can, knowing what you're working with. This is where you're seeing the dynamics of the relationship, you're getting all the history. You are also starting through this map information gathering to start your case conceptualization. Of course, from family to family that you work with, there's going to be common things that you see come up or common questions that you ask, but try not to follow this so much as a recipe. Just like a map, any town you go to, there's going to be roads and intersections and different things. The terrain is still different, and you have to recognize the uniqueness and individuality of each family. So not to get in a rut of asking the same questions, but knowing where you need to dig deeper to gather the territory, kind of find out what you're working with and who the support systems are and whatnot. So mapping the territory. All right, second step, oases and obstacles. I think this is really important, and it brings to mind several examples in working with families that I want to know what things they have in place already. What have they tried? What have they done? Maybe they're seeing a doctor for medication. Maybe they have individual therapists that they're working with. Maybe they have a really close family system or a really strong faith support system through their church or some spirituality, some cultural things that are strengths and support for them. And so we want to recognize those, because that's going to be a really important part of being having a competent therapy outcome, is recognizing how they can continue to utilize those. Now, of course, the obstacles are things that we tend to gravitate to and focus on, but those are what is getting in the way, what is hindering them from moving forward or creating change. And sometimes this will take the form of the things that are listed here in the bold, whether we are doing an assessment, we're trying to rule out things like medical issues, maybe we're trying to figure out where they are mentally by using a mental status exam. And then if you look at it from a case management perspective, just how are they meeting life's basic requirements? And are there obstacles to those? I've had families where finances are the obstacle, or a vehicle is the obstacle, not having running water or clothing. So it can kind of fall across the board. Maybe some people have obstacles that they have some disabilities, such as not being able to read or communicate. All right, let's go into the third step then, is selecting a path. So we've mapped it out. We kind of know what we're working with. We know what's helping and what's hurting, or what's lacking, or what's in abundance. And now we have to choose the path. We have to, we're at point A and we want to set what point B is, or the goal or the destination. And doing that, we're trying to choose then our vehicle of how we're going to get there, or our therapeutic theory or style. And within that, we're also creating a treatment plan. So we have the road, point A, we want to get to point B, what vehicle are we going to take, what theoretical orientation are we going to take, and then what are the resources or the app, like the MapQuest, the directions, the point by point. That's your treatment plan that you're going to articulate at this point. So where do we go after that? The next step is tracking the progress. This is the documentation piece of it that tends to get really heavy in your clinical work with clients and families. It's very important, of course, for billing purposes, insurance purposes, but it also keeps you accountable, and it keeps them accountable by always doing this, keeping your finger on the pulse. Where are we at? And if we're going to keep using the travel analogy, it's kind of like when you check your smartphone and it says, you've gone this many miles and it's this many more minutes to your destination, or there's some road work up ahead, or there's things that are going to impact the treatment goals that we have. So you have to reassess sometimes, you have to make improvements, you have to change goals, and all the time making sure that those goals are still reasonable and attainable. So tracking is a really big deal. I've even had, just, I guess you would call them come to Jesus meetings with clients and families. When you do this step, you start to say, okay, where have we come? And I've literally said, it feels like we're spinning our wheels here, that we're not making any movement. Let's go back and talk about those obstacles, what's getting in the way. And so it's not just moving through the steps smoothly, you get to 1 to 5 all the time, but that you actually do have to sometimes go back to a different step so that you can move forward. In leaving a trail, I know I jumped the gun a little bit here on the documentation piece about tracking your progress. For me, documentation does start in step 4 as far as the percentages of meeting the treatment goals that we set, or seeing where we're at. But overall, when you wrap it up, you want to be able to show your entire path and what you did and what worked and what didn't work and who was involved and all the releases that were signed and all of that sort of thing. So leaving a trail, basically having the path that you went highlighted and all the steps along the way that weren't expected and whatnot. You guys kind of get it. So that's what this author in this book is saying competent therapy is steps 1 through 5, and again, we'll go more in depth to those. So on the discussion post, or what I'll have you turn in lieu of class, is I want you to go ahead and look at this slide. I'll have it also copied over to you, but look at this scenario and then think about the 5 steps we just talked about, mapping this successful therapeutic journey. And for each of the 5 steps, I want you to just briefly outline kind of what you would do with the family, the therapy plan for the family below. Use those steps to guide you and outline a therapy plan for the family. So that was it for chapter 1. Again, I know I went through that kind of fast. It's nothing new that you haven't heard before, maybe just talked about it in a little bit different way. Chapter 2, Research, Ethical Foundations. This is just a brief overview of the things that you guys, again, already know, that you, as a therapist, especially when you're licensed, are going to be expected to keep up on the research that's happening in the field, that we constantly are finding new and better and different ways to do things. This slide here talks about the 4 different strands of research that inform our practice, and that's evidence-based practice, common factors, evidence-based treatments, and review of marriage and family therapy evidence-based. And of course, we'll have slides for each one of these. So let's just start with the evidence-based. So this is using research to inform your clinical decisions. If you want to become an evidence-based practitioner, you're going to have to be willing to invest time to learn new things. You can't just keep doing what you learned as a graduate student and think that that's going to get you through the next 20 years with never adding new or different tools to your toolbox. You have to adapt your practice to what the latest findings are in the field. And also, we've talked a lot about that same tool not working for every single client, that you might need to learn something different or try something different, and not just rely on the same old things. And especially being an evidence practitioner means that research has informed that there's value and substance to doing what that it's worked for clients, I guess, for lack of any other better words at this time. So what about common factors? So we looked at in the book Michael Lambert's work on common factors, how he reviewed some of the outcome studies, and basically what was change attributed to when he looked at the general trends. And so let's just go ahead and skip down to the next slide so you can see. So according to Lambert, he said change was 40% based on factors that were going on with the client, 30% the relationship between the client and family and the therapist, 15% had to do with the model that the therapist was using, and maybe 15% was that placebo effect. Okay, so this is interesting. I want you to think about this breakdown for a little bit. Just take a minute and look at it. Client factors 40, relationship 30, the model you're using 15, and the placebo 15. We're going to look at one more table here. So this is Wampold's common factors model. So again, it's different than Lambert's. It's including more than just one therapeutic model. And he breaks it down into these 3 categories, saying 22% of the time we don't even know why change is occurring in the families. But I think that 8% of the time it has to do with the therapeutic model, and 70% of the time, it has to do with just general factors. That's not very specific, is it? So I'm wondering kind of what you think. How would you break down the percentages of the influence, what influences change in families? I think just based on my work, I do believe it has a large percentage to do with the therapeutic relationship, but it also has to do with knowing what you're doing, having that path, using a treatment plan, and I guess I would have said I was pretty eclectic in the way that I did my therapy, so I did pull from a lot of different models, so maybe the percentage would be a little bit less in there, and client factors do play a part as well. So I might be more along the lines of Lambert's, in that sometimes families did really want to make change and wanted to get things better in their family, but they just didn't have the resources to do that or the support systems to make the change that they really wanted to make. So 70% really what's going on with them and how you are interacting with them. And then a little bit of bump comes from just like that you are following this plan. So the client factors are, again, looking at those oases, those support networks, what's going to motivate them to engage in the process, and then how can you adapt then based on what they need and want, what's going to motivate them with what you already know how to do, how you've used those tools in your toolbox before. Can you think outside the common use of that tool or bring about a different way so that the client can meet their goals? I think one of the big motivating factors for clients is whether they feel like there's hope, whether there's light at the end of the tunnel. So I want you to think about, when you reflect on this lecture, is how as a therapist you could create hope. And think about hope for families, because we were doing family therapy. So not so much individual clients, but how would you create hope in a family situation? And then, why do you think the quality of the therapeutic relationship has more impact than specific techniques? So again, you'll have time to reflect on that in the assignment related to this lecture. Next, we'll just touch on evidence-based therapies. As you guys learned in your research class, and through all the different classes that we've had in this program, that really we're looking at research and randomized trials to come up with these empirically supported treatments. We want to utilize empirically supported treatments because of the scientific support that they have. And they also give us structure, which is, as a new therapist, is very welcomed, because we want to know more of a recipe of what to do. And then it also helps us narrow down, this works with this particular population, with this particular issue. Scientifically, it's supported, research supports this. And so I know for myself, using empirically supported treatment as a new therapist, it was very comforting, because I felt like I had something to follow when I wasn't quite sure. Sometimes the disadvantages can be just the availability of an empirically supported treatment, or the extra training that you would need, and sometimes that can be very expensive. So it just depends on the agency that you're working at and what they're asking you to follow. Sometimes they'll provide you with the specific training or cover the expense of what they want you to do. So just an overall perspective then is any therapy is better than no therapy. That therapy for evidence-based just kind of refines what we know. Another word maybe would be validate what we know works. There's been more trials and research on that. In family therapy, why it's important to just keep up on the latest things is kind of like a work in progress. We're always refining and redesigning and finding out what works. And then there's new factors that come into family therapy. For instance, social media was a thing when I worked with families, but I think it's so much of a difference now, even then from when I worked with families. And so things are always coming into play. We need to consider those new factors. One thing I wanted to point out, and I'll ask you to do as part of the process of looking at chapters 1 through 3, is on page 128, there is a great listing of resources for evidence-based practices. And so I want you to go ahead and take a look again in your book on page 28. So it's been a while since you've had ethics, but hopefully there's been strands and threads of you talking about it through each one of the classes. It's so important. It's important for you maintaining your license. It's important to providing the best possible treatment for your clients. And I think the biggest thing I can say overall is go about ethical decision making very carefully and with a lot of supervision. In that, just because you're brand new, or even if you've been doing this for several years, I think the best advice is to consult and to get supervision in situations where you're unsure instead of guessing. So here's another just quick activity that I want you to do about ethics in therapy. and a few questions that you can follow up to help you think through that video. So when we talk about standards of professional practice, we're looking at 3 different levels that's going to govern our behavior: laws, ethics, and standard of care. And sometimes it seems cut and dry, and other times they kind of overlap and you're not sure which trumps the other. Well, you must know that laws trump everything else. You do not want to break the law. So the laws are going to tell you what you must or must not do. And again, not even thinking of a great example off the top of my head, but if, in practice, just remember that if the law is telling you to do something or not to do something, you go with that over an ethical obligation for your practice. And I know this is all review for you guys, especially the 5 ethical principles. So just take a second here and look at those again. And think about how they might come into play for family therapy. For instance, non-maleficence is doing no harm. I think one thing I struggled with is knowing that I wanted to go in and help the families open up and communicate with each other, but also recognizing that sometimes not all family members were on board with doing family therapy, and that you needed to recognize maybe when I leave here and after I've encouraged everyone to open up, maybe one of the family members could potentially become abusive and create more harm. And so that's one way I've seen an example of how ethically I need to be aware of my environment and not doing more harm than good. So standard of care, I guess, just because my husband is an attorney, it's kind of the easiest way to say this was, what would a reasonable person do? So any other reasonable therapist that's been educated, would they act in a similar manner to you, and kind of using that as a standard of care. So as it states in the book, and I just want to point out again, when we think through these legal and ethical concerns, we recognize that family therapy is similar but also has its differences, especially in working with minors with their parents or child abuse reporting. For instance, if you're individually seeing a child and they report abuse to you, you may not have to have much interaction with that family member that they're reporting about, but when you're the family therapist, you're kind of going in front of that entire group again and working with that dynamic firsthand. All right, that's it for chapter 2. Let's go ahead and jump into chapter 3. So let's talk about the philosophical foundations of family therapy theories. The biggest thing is to not, when you're looking at a family issue, to not blame one person. And that might seem like common sense. However, it's also easy to get sucked into the family dynamics of saying it's Billy's fault or it's Jenny's fault, that their behavior is disrupting our whole life. And maybe it is, but looking at a system, you know that it's bigger than that, that all of the interactions and the patterns and the behaviors are woven together to then make what's happening and maybe being most focused on in that one person. So when you're looking at a theory, the author talks about dating versus marrying theories to see what fits for you by so-called playing the field or trying out some different therapists theories to become aware of more of who you are, how it matches up with your skills and knowledge base and your style altogether. So knowing that maybe how you start out might not be how you end up, that you can change, you can reassess those tools in your toolbox and look at them differently and how you will use them as they relate to a theory. So I guess this slide is really just meant to tell you that you don't have to pick one right now and stick to it forever. It's more about as you learn and develop, you may find yourself trying a different theoretical approach to family therapy. And part of how you will do that is looking at the bold language here and just how do you think of humans? Like, what does it mean to be a human? And thinking about how people learn and change. So those two things are really going to play into the kind of therapist you are and how you think about what your role is. The next slide is going to probably be helpful to know more of what I'm talking about. And the four categories that we'll look at is modernism, humanism, systemic, and postmodern. So let's just go ahead and take a minute and look at this next slide here. So down the left-hand side, you see truth, reality, therapeutic relationship, and the therapist's role in the change process. So maybe the easiest way to sort this out is for you seem all to know kind of how you are in relationship with clients. And so look at that one first and see which one fits for you. Expert, non-expert, participant in the system, empathetic other. And then, if you think you kind of are going between one or two, go down and look at that next column, therapist's role in the change. I know myself, based on having done therapy and the way that I think about life just in general, I would put myself in the postmodern column. But where do you think you would fall? And you'll have a chance to reflect on that as part of our assignment for this lecture. Let's talk a little bit more about each one of these. Modernism, the thing that stands out to me the most is the therapist as the expert. That doesn't always fit for every different person's style or personality, but for some people that is very comfortable to assume the role of the teacher or the mentor as the expert. And this fits a lot with the psychodynamic and CBT approaches. Moving on to humanism. This is more of the subjective truth. You're going to see a lot of support and nurturing to promote change. Names that stand out in regard to humanism would be Rogers, Gestalt therapy, Regina Satir's communications approach. So this one might fit for you. Next, we're going to just peek at systemic. All behavior is a form of communication. There's an emphasis in that contextual truth. And this is really looking at what I talked about that first slide, that it's just everything is interwoven. It's not just one person affecting the dynamic, that it's a broader context. Now, one more to talk about here, postmodern. The objective truth can never really be known. Objectivity is not possible. Okay, so language and words greatly affect how one's identity is shaped. So when you talk about what influences postmodernism, it's constructivism, social constructivism, and post-structuralism. So I think the combination of these four slides that we just went over and the table will give you a good overall view of a feel of what are these four different ways of looking at it. So, and finally, in wrapping up with chapter 3 and in today's lecture, you just want to know that overall, it is important to be consistent in how you're going to approach. You can integrate things from other theories and adapt those techniques and those interventions. But the best way to get from point A to point B is choosing that vehicle that you're comfortable driving, that fits you, that represents your skill level and your knowledge level, and you feel like you can navigate it pretty confidently. Okay, so that's why it's important to commit to a theory. Still recognizing that, yeah, you eventually down the road with different training might incorporate a different vehicle, but when you don't know what you're doing and you keep switching and you keep doing different things, it can certainly disrupt the smoothness of the journey. So that's it for chapters 1 through 3.